Good morning. Welcome to a conversation with experts about congenital heart defects. My name is Kapil Kumar, and I'm a member of the board of the 22Q Family Foundation. We have some guests with us tonight, this morning, I guess I should say, not tonight. Randy is a incredible advocate for Heart of Illinois. She works with the hospital down in Peoria, in Illinois, and her daughter Kinley has 22Q. Randy, thank you for joining us, and thank you for recruiting our guests today. I will let you take over and introduce them and lead the conversation.
Okay, well, thanks again for putting this together and letting me join you. So it's a great honor. Yeah, so I have had the privilege of knowing these ladies for 7 years now. They are women extraordinaire, if you will. These ladies have such a caring heart and they're so compassionate when it comes to not only their patients, but even patients that aren't theirs, and including their families. And they're the whole package. I know that they put all that they have into the care that they give. And I am so grateful that they are part of Kinley's care team. So today I will introduce you to Dr. Priti Patel. She is a pediatric interventionalist cardiologist, correct? Yes. And Becky Todd, she is an APN for the pediatric cardiovascular surgery. They both work at the Congenital Heart Center in Illinois, which is in Peoria, Illinois, part of the Children's Hospital of Illinois. So ladies, thank you so much for joining us today.
Thanks for having us.
Thank you for having us today.
And that was quite an introduction. Wow, thank you.
Good thing it's being recorded, right, Becky?
That's right.
So we have some questions that have been submitted, and we're just having a conversation with you guys and letting others know more about the CHD side of 22Q, because not all of the kids with 22Q have CHD, but many of us do. So, Becky, could you tell us how common is CHD?
So congenital heart disease is very common. The most popular thing you'll hear is 1 in 100. So, out of all the live births, 1 out of 100 will have some type of congenital heart defect.
Right. So it's the most common birth defect here in the United States. And it is, it's kind of something that I didn't even realize or hear about previous to my daughter's diagnosis. So it's pretty amazing. And then now that I know what I know about it, I've met so many people. So I'm grateful not to be on this journey alone. Let's see, Dr. Patel, can you tell us what are some symptoms that we should be aware of?
So depending on the heart defect, the symptoms can vary. The most common one would be if it is an interrupted aortic arch, which is the most common congenital heart defect in patients with DiGeorge syndrome, is if they are picked up early on by fetal echo, then we can anticipate and we can start them on prostaglandin right after birth. But if they are not, for the first few days, they still do okay, but then they start to have, their legs are kind of not well perfused. The color is on the bluish tinge side, not feeding so well. Urine output drops because of low cardiac output from that standpoint. If they have truncus arteriosus, then initially they may not be blue, but then slowly they can start to be blue. They can have signs of pulmonary overcirculation early on, where they are breathing faster than usual. They have some respiratory distress where their rib cage kind of goes in and out. Below the rib cage, it can have retractions from that standpoint, feeding issues, weight gain issues from that standpoint.
Well, I think you just summed up our kids, right?
Yes.
Yeah, yeah. I'm curious, Dr. Patel, and for the guests that we have on as well, people that are joining us today, feel free to raise your hand and we can unmute you and ask for questions. But and Randy, I apologize if I'm cutting in here and you're going to cover this, but Dr. Patel, I'm curious, two things. One is, what are the most common heart defects and heart disease forms that kids can be born with? And then do you see a lot of variation between the most common and what presents in kids with 22q?
So the most common, so the defects that are common is called conotruncal heart defects, and that's mostly the outflow tract. And that is because during development, there is problems with the neural crest migration, and that affects what some of the pharyngeal pouches and the arches that form. And that is the main reason for the congenital heart defect. So they have some form of outflow tract, meaning the blood vessels that come out either from the right side of the heart or left side of the heart. The one that is the most common is the interrupted aortic arch, where the aortic arch, the aorta comes out from the left ventricle, gets to the head and the neck vessels, and then you can have interruption there. So the most common one is called type B. And what that means is there is an interruption between the left subclavian artery and the left common carotid artery. So that's the most common one that we see. The second is truncus arteriosus. So normally when the heart tube is forming, it comes off as a single vessel, then it septates and then spirals around itself. And then it forms the aorta and the pulmonary artery. And then the pulmonary artery comes in the front and the aorta goes in the back. So the truncus is where that septation stops at some point in time, and it still comes off as a single vessel out from the left ventricle, but then you have the pulmonary arteries coming off of the aorta. So it can come as a main pulmonary artery coming off, or the two separate branch pulmonary arteries can come off the aorta separately, either from the ascending aorta or from the descending aorta. One can come from the ascending, one can come from the descending. So the truncus is the second most common congenital heart defect seen in patients with 22q11. The other one is tetralogy of flow, where you have the overriding aorta and then pulmonary valve stenosis of varying degrees from that standpoint. The right aortic arch is more commonly associated with tetralogy of flow in patients with DeGeorge syndrome. The other forms could be a right aortic arch, aberrant right subclavian artery, or a right aortic arch by itself if somebody has no other congenital heart defect. But those are the ones that are more commonly seen. And interrupted aortic arch and truncuses are the ones that we most commonly see. And in patients who have not been diagnosed prenatally by fetal echo, if we see those heart defects, then we look for DeGeorge syndrome.
Thank you.
Kinley for, we did not know Kinley prior to birth had the heart defect. So I want to kind of sum up what Dr. Patel just said. Obviously, if you have a fetal echo, you can get it. They're not going to be able to stop what's going to happen, but they're going to be able to put you in the place where you can get the best care for your child at that time being born. So that's important to know, that there is no cure for congenital heart disease. There's only treatment. And also I wanted to say that even if you're not, or your child is not diagnosed at birth or prior to birth, things to look for when you get home, as Dr. Patel mentioned, was trouble breathing, like recessed breathing, feeding difficulties, of course, turning blue, and just being really cold to the touch. Those are some things to look for once you get home and not previously diagnosed. Also, if you already know that you're diagnosed for 22q, which I'm sure you're already being evaluated for this. But that's definitely something to check, is to make sure that you or your child is being checked by a cardiologist as well. That's just because heart and CHD is very common within the 22q family.
Right,
Yeah,
and I
you hear-
just to add to you, Wendy, you know, that kind of goes hand in hand. You get the George diagnosis, and obviously the echo will be ordered quickly thereafter.
Right. That's exactly right. And so, so my daughter does have the interrupted aortic arch type B that she was talking about, and we did not know previously. So she had all those things happen.
Yeah.
You know, she's had breathing difficulties, feeding difficulties, and was very cold to the touch. So that's when we were still in hospital at the time. So that's when we knew to get her checked out.
So Brandy, I was just going to ask if you could share your story at a high level. And so that
was pretty much it. I mean, so I had her via C-section. Everything was normal. So we thought. And so it was second day of life, like overnight, when I noticed she stopped feeding, because I had her in the room with me. And I noticed she was breathing really funny. So, you know, in the mornings when the pediatrician comes in and does their rounds, I ask them, like, you know, something just doesn't seem right. And sure enough, he heard a heart murmur. And so I was not in a place that had a NICU. So they arranged for transportation to go to Peoria. So it was very difficult. I wish that we would have known previously so we could have been in Peoria when I delivered. But these are things you can't control, you know. The best thing is to do, and which I know a lot of states, correct me if I'm wrong, Dr. Patel or Becky, but I know Illinois has added full socks to all 4 limbs as part of newborn screening, but I don't know if that's nationwide. But that is something definitely to ask for as part of your newborn screening.
Yes, so that is still true in Illinois, that before you go home. So it's usually done after 24 hours.
Mhm.
And the reason it's done after 24 hours is because the PDA is still open by then. So hopefully the PDA starts to close, that you can pick up some of those congenital heart defects that are dependent on the PDA. So if the PDA starts to close, then your saturations vary between upper limbs and the lower limbs. So Illinois still does that right now, that everybody gets a screen. Now, you could still have a defect, and if your PDA is still open, you could pass the test. That doesn't mean that, well, I passed the test, why do I still have this diagnosed 2 days later or 4 days later?
Right.
If the PDA is still open, we cannot pick that up.
So, Brandy, actually, you know, we had kind of the opposite end of the experience from you guys. You know, my son was diagnosed during our 20-week ultrasound, and as Dr. Patel had mentioned, you know, it was a growth ultrasound, and then they were able to do an echo and see he had truncus arteriosus, and they actually couldn't tell whether it was a right arch or a left arch, or it ended up being a double arch. And so he was, I think, the 10th recorded case of the ring, you know, kind of the aortic ring and truncus together. But you know, when he was born, they had the whole team of experts there, and you know, within 10 minutes they took him from we were at Prentice and next to Lurie's, and so they took him within 10 minutes from Prentice over to Lurie's, and he had his open heart on day 4. So you know, that was kind of our story and our experience, and you know, he had the artificial valve put in, you know, the new graft they put in, and he outgrew that around age 3. So you know, we had 4 caths between the first surgery and the second surgery, and then he's been clear since then, I think.
Yep.
Yeah, I'm glad you mentioned that, because that's another thing too. Obviously, if you if you know previously that your child has a genetic disorder, it's probably best that you go to a place that has a NICU for delivery. Also, I wanted to touch on, Capella had mentioned it, and for my daughter as well, is many of the children that have a CHD, it's not just one. Is that correct, Dr. Patel?
Yes.
Yeah, so Kinley had two. She had the interrupted aortic arch type B plus a VSD, and I know Liam also had multiple. And so it's usually not just one thing working against them. It is multiple things, and there's multiple stages to repair, if you will. Which leads me to my next question for Dr. Patel. Can you tell us what are some treatments and some of the non-invasive treatments?
So depending on the heart defect, like we talked about, that if it's an interrupted aortic arch, then it is something that has to be fixed surgically. If it's a truncus, that has to be fixed surgically. Tetralogy of Fallot, that has to be fixed surgically for the most part. Then with the newer advancement in tetralogy of Fallot, if you have significant pulmonary valve stenosis, then if the PDA is something you can put a stent in, then you do not need surgery early on. You can at least get away with doing one surgery less from that standpoint and then go for complete repair later on. But for the most part of them, it's an open heart surgery that they need early on in life. After that, if they need any interventions, then it can be done in the cath lab. If they have recorrectation after interrupted arch surgery, if they have branch pulmonary artery stenosis after truncus surgery or tetralogy of Fallot surgery, then we can do that in the cath lab in terms of ballooning or stenting it.
Right. So it's important to note that just because your child might have a congenital heart defect, it doesn't mean necessarily that it would be open chest surgery. Now, there's a possibility of that, but there are other advances right now. I mean, I remember when Kinley was born, and her cardiologist, Dr. Knapp at the time, he was like, "This is how we treat this right now today. 5 years from now, it might be a completely different story, completely different treatment plan. But, you know, just as of today, this is what we do." And I will go ahead and say that we've lived that life because Dr. Patel, thankfully, was able to do a cath procedure on my daughter just back in September instead of doing a full open chest. And so I'm really excited to say, like, I just for sure thought we were going to go straight into open chest surgery again. So luckily, she worked her magic and was able to get the valve open back up to the size that it needed so she can grow a little bit bigger before we have to go to that next step.
Kinley sprayed her pixie dust.
Yes. Oh, she's something. That's another thing. These kids are strong-willed.
Oh,
Yes.
But
Yeah.
they have to be. They have to be to survive this.
Yes, they have to be feisty.
I remember being told, I think like right before we went home from PICU after Kinley's first surgery, which we had a very extended stay. That's not normal, but anyway, I remember being told that no, you don't treat these kids like any different kid. You know, like you still have to be strict with them. You still have to make them follow the rules. You know, you still have to do all of the things that you would. You don't wasn't necessarily spoil them just because they still have to grow and survive and make the right choices.
That was Gail probably.
Yeah.
Yeah, it was Gail. Becky, can you tell us what are some other complications that can arise with CHD, such as your neurodevelopmental issues?
Yes. So, you know, with these,
We're having a hard time hearing you, Becky.
okay, sorry. Can you hear me now?
Yes, that's great. Thank you.
All right. So something that I've become passionate about is, you know, the neurodevelopment with kids with congenital heart disease, and, you know, hand in hand comes DiGeorge syndrome. As you guys know, it's just not the heart that we're dealing with. There's a lot of other issues that come with DiGeorge and congenital heart disease, and one big thing is just neurodevelopment. So I think for parents, what I would say is we have to, you know, focus on recognizing and screening and detecting early in life, and trying to get our kids set up with all the resources that they need to be successful. And that is something I've been doing this now for 20 plus years. And 20 years ago, this wasn't talked about, but as these children grow and there's so many, you know, advancements, we want them to be successful in life, and there's no reason they can't be. But I think what they need is the right resources. They need help in school and identifying with education plans, having physical therapy, occupational therapy, speech therapy, all involved to make sure that these kids are, you know, developing the way they should. And that's something as parents, I will tell you, you have to be these kids' advocate. You know, we on the medical side, we're trying to get better to give our kids more. But as everybody knows, the school system sometimes can be hard, or wherever you might live, resources for speech and therapies are hard to get. But you know, my big thing with neurodevelopment is that these kids learn in different ways, and as long as you can help them figure out how they learn, they can be successful. And it's really exciting seeing the strides that kids are starting to make. And you know, coping, you know, these kids have been through a lot, you know, setting up, you know, if they might want to talk to someone outside of their family. I think those are all really important things to think about as these kids get older. So that's my neurodevelopment. I think that's very important. You know, we can fix their heart, we can, you know, do those type of things, but once their heart's fixed, we also want them to be able to live and participate in activities and, you know, be successful in school and someday get a job, you know. So that's, you know, what as parents, we all have to work towards that. And it takes a lot of effort sometimes, but I think that's when you call on your doctors and your nurse practitioners and your nurses to help be your medical advocate when you're going to the school.
Yes, absolutely. And early detection and early services really make a difference too. So the earlier you have your child on these services, the more help they get, and it just continues, you know, for as long as they need it. So most kids will need all of those services.
Right.
And so what's really great about the 22Q Family Foundation, and Phil can talk more about this, is within the website, if you go to Education Station, is that what it's called, Phil?
Yeah, Education Station, yep.
Yeah, so if you need help with your child's IEP or service plan, 504, whichever one that your child has, we have this amazing resource that you can use, whatever help you need, or you don't even know where to start. You just fill out this form and we will connect you to the expert of service plans, and she will help you walk through and get the services that you need for your child. So that is a fantastic service that the 22Q Family Foundation offers, and it is totally free. So please utilize it.
That is amazing. That's great, Randy.
Yeah, I was actually gonna just try and put in a plug for that, but you did it for me, so thank you. Yeah, Donna Cutler Landsman, she wrote the book on educating kids with 22q deletion syndrome, and She just put out the 4th edition, and she is our educational consultant. And she's great. She's amazing. She does a wonderful job. We give all families 5 hours free of consultation, and she works with the families, with the school districts, and with providers. And so that's wonderful and hugely beneficial to the families. We also have the Career Pathways program, and Career Pathways is a gentleman, Jason Osborne. He volunteers his time and works with kids and young adults and adults with 22Q to help them build their resume, to help them understand interviewing skills, figure out what their passion is and what they will be successful at. And that's also done for free. So what are some other resources, Randy, Dr. Patel, Becky, that you guys can talk about and recommend for families? I know here in Illinois, we've used early intervention, when Liam was born until he was 3. That's a program through the state. What else would you guys recommend looking into for families that are diagnosed with congenital heart disease?
Well, I know here at our hospital, we do have our own neurodevelopment clinic and program. It really starts, in the inpatient world. And then when we do see kids who have needs, we recommend that they come and see us at the clinic. It is evolving. I know a lot of the children's hospitals with congenital heart programs do have neurodevelopment clinics. So you can definitely start there. But as far as Illinois and out, I feel like our resources are a little bit limited. I don't feel like we have a lot of aggressive programs that generalize in those type of things. You can probably find good smaller things here and there, but I would definitely, I think what you have through your foundation is wonderful. But I also think that starting at the neurodevelopment clinic at the hospital is a good start.
Yeah, that's a good start. And even 22Q Family Foundation, or the 22Q clinics that you can find, if you need to find one, you can go to the 22Q Family Foundation website and just type in your location. But that is also part of the 22Q clinics. I can tell you it's kind of difficult to get into those, and you want to be in those by age 6, I believe is the age. So the earlier you can get on the list, the better. And like I said earlier, if you get the services for early intervention, that's the Illinois program. It really truly helps your child be the best that they can be. As far as other resources, I know that American Heart Association has some resources available for CHD. Let's see, Conquering CHD also is another great foundation that you can use. They will help give you information or some resources that you need depending on whatever it is that you're looking for. If your child is going to be a young adult, or graduate and move on, or if you yourself are an adult with CHD, the Adult Congenital Heart Association is really good to help you out. And there's also a Pediatric Heart Association. So these are all resources that I believe will be listed on the 22Q Family Foundation website. But of course, you can just go to them individually, and they'll help you and support you in whatever way that you need. A lot of them have different programs, such as, I know Illinois has a governmental program that will help with meds and transportation to appointments, and I'm sure each state has their own, but it's something to definitely look at and investigate and see what you need and what organization will be the best fit for you. The only other question I have that somebody submitted was for Dr. Patel and Becky is, what is your experience specifically with 22Q?
We have a lot of friends here. Oh, I don't, you know, I would say that as parents, you know, like we've already talked about, diagnosing it fetally helps you prepare. But if our patients do come like Kinley, you know, we just have to get the diagnosis and take one thing at a time. But our experience with our kids with DeGeorge syndrome, they're some of my favorite patients. These kids are, they're fighters. They do have, several of them have a lot of other things going on. But personally, I know Dr. Patel and I have a lot of our kids are very close to our hearts. We could probably rattle off 15 of them that we all know and see, you know, currently. And I don't know if that answers, I don't know exactly what they want to know, if they have any questions. You know, the kids with the DeGeorge syndrome, they do have a lot of other issues, you know, feeding issues, you know, developmental, like what we already talked about. We know that these kids have a lot of additional needs, but I do, the nice thing about DeGeorge and congenital heart defects is we are getting better as we go, and we are learning more and more about them every day and hopefully making things better.
Yeah, I think that I know that some people that live in a rural community, when their child was first diagnosed, their doctor didn't know anything about 22q, never even heard of it. So I think that's probably where that question stemmed from. So it's very hard to get services sometimes in a rural community. And get a specialist that knows 22q and knows all, you know, all the things about it. And so I'm sure that's probably where that came from.
I think the most important thing is that as a parent is, what did I do wrong? Nobody did anything wrong. God just made them special. And that's what I tell all of them, is that God just wanted a special parent for a special kid.
Yes, amen to that.
Yeah.
Yes, thank you so much for saying that, because that's really important. I know as a mother, that's exactly kind of where my thoughts went right away. After Kinley's birth, I was like, what did I do? What did I do? So it's important to note that. I mean, it is formed probably before you even know you're pregnant, right, Dr. Patel?
Yes, even before you know you're pregnant, the heart has already formed. So nothing anybody did. And that is true for any defect. Now, there are some that you can explain, but for the most part, especially the congenital heart defect, is something that nobody did anything wrong. Mm-hmm. And with DeGeorge, it's like about 90% of the time it just happens. It's not even inherited. So it's kind of like tough to even say if it is, well, does anybody in the family have it? Did anybody have it? Do I have it? Because 90% of the time it just happens. From that standpoint, only 10% is what is inherited from the parents.
Well, and Dr. Patel, if I'm not mistaken, you know, the onset of DeGeorge, the genetic change, that happens in just like the first few days after conception, right? So it's not even a couple of weeks. It's when the DNA is being written. Yes, yes. And then the heart has already formed before you even know you're pregnant. So it already is there from the very beginning. The other thing we see as in our experiences as they get older and adults, I have a few patients that I have done
transcatheter pulmonary valve in them, so to avoid open heart surgery. But the other thing is kind of like some of the psychological effects that can happen because of the genetic mutation is something that if we can diagnose them early on and help them early on with counseling, and even if it needs medications before it gets to the point of really affecting their life and the family's life, I think that is the most important thing as they get to be adults.
Yep. All right, Randy, do you have any other thoughts, or Becky or Dr. Patel, anything else you guys want to share?
And I was talking to Becky, I looked through your website and I was telling her it's amazing. It's like we can get more information and knowledge from it as telling you.
We're actually in the process right now of revamping it. It's a little bit, kind of outdated and a old platform. And so thank you. We would love any feedback you guys have on our website. For those watching, the 22Q Family Foundation website is 22qfamilyfoundation.org. Feel free to email me at kapil@22qfamilyfoundation.org. And I can always forward any questions to Randy or to Dr. Patel or Becky, the APM that's with us as well. And we are happy to take input from families on things they'd like to hear as well. Randy and Dr. Patel always, feel free to tap us on the shoulder if you guys want to talk about things, if you want to, if you want to do anything special related to, whether it's Heart of Illinois or Children's Hospital of Illinois, if you guys want to talk about any of the programs you offer, we're always happy to put these types of things out there. And
definitely.
Wonderful. Thank you.
Thank you so much.
Okay. Well,
Thank
thanks,
you,
everyone.
ladies, for joining us today.
Really appreciate
Thank you,
the time.
Randy.
It was great.
Oh,
All right.
we do have one question that just popped up in the chat bar.
Oh, yeah.
Have a minute.
Yeah.
Okay, do either Dr. Patel or Becky have any suggestions for a 19-year-old boy transitioning into adult care for his congenital heart defects? Probably will transfer to Children's Mercy Hospital in Kansas City to the University of Kansas Hospital or St. Luke's Hospital in Kansas. So I know that our congenital heart center here starts the transitioning care at age 14, correct?
Yes.
So I guess,
So
You guys
that
have
is
a program?
something yes, we do have a transition program, and we kind of like start around 14 is when we officially started. If there are some kids who want to know more, we start even at 12. It's more so just to get them to understand what their heart defect is, what surgeries they have had, what interventions they have had, what to anticipate as they get older. Would they need any more surgeries? What to do in terms of remembering to take their medications, if they need antibiotic prophylaxis. And then once they go to college, at least that way, we give them a passport, which has their heart defects, a heart diagram in it, all medications, what they are on. So that way, if they go off to college and they have to go someplace, they have it with them. So they can take it with them to any emergency room that they go. So that way they don't have to call mom at 2 in the morning. Mom, I'm here, but I don't know what my heart defect is.
Right. I know that.
that's a suggestion for Michael then, right? He could do that for his child, or you can see if his cardiologist can work something like that out for you.
Yeah, I would definitely be curious if Children's Mercy has a program like that. I know Lurie's has a terrific transition program, but they like to keep their kids as well. So I think that Lurie's actually follows their patients on the heart side, at least until like their 20s and 30s. I know people that have had surgeries kind of in their late 30s, early 40s that have actually been done by the surgeons at Lurie's as well. So, obviously, we're fortunate and a little bit unique in that you have Northwestern, Lurie's, and Prentice Women's Hospital all kind of attached, and so they have some programs there. But I hope that most hospitals will try to have a transition program to help figure out, how to move to an adult program at adult hospital from the children's hospital. So I think that would be a good place to start.
So we are unique here is because we have the congenital and the adult congenital in the same place. So we are all still in the children's hospital.
Sorry, can't hear you.
So we are unique in the sense that we have the congenital and the adult congenital in the same place. So we don't have to send them over to any adult hospital. We just change the
Got it.
physician. So even like Kinley, when she gets older, she'll still stay with Dr. Knapp because he's an
Right.
adult congenital physician, but it's still in the same office. So that's the unique thing about us here is we don't have to transition. A transition is just to make them understand, but we are not transferring care to any place else. They still stay in the same practice, in the same program.
That's great. That's awesome that you guys are able to do that for your patients. Wonderful. Okay. Well, thank you all so much. Enjoy the rest of your day. I hope that it is beautiful and wonderful and not as frigid as we're getting in much of the country right now. Hopefully people can enjoy some sunshine and fresh air.
Thank you
Take
so
care.
much for putting this together.
Oh, it's all about you guys joining us, and that's what we're so thrilled for. So thank you for that. Yeah, really appreciate it. Everyone.
Thank you, everybody.
Bye-bye.
Bye-bye.